Surgery is important because that involves the implant fixture that gives the foundation for that restoration. And thirdly, the maintenance part of it, okay? And when we look at these factors, we look at the hierarchy in implant dentistry. This was first presented by Dr. Sonic several years ago, and he says that we have to be able to establish a baseline in order to make the restoration a success. And as you go up this ladder from here to here, you start to lose control. You start to lose control. So how about if we combined all these processes and we established a baseline right on the day one that we place the implant? Okay? That will accomplish a lot of things for us and also for our patients. Establishing a baseline requires good primary stability, bone quality, quantity, surgical techniques, and a mixture of a lot of different things that we do every day in our practices. The point I'm trying to make is that no matter what you look at, the way you look at things, the bottom line is that the patient wants those dentures immediately. They want that restoration the day off. This is the literature that we look at, survival rate of implants. And you can see a wide variety of literature that has proved the success rate. But really, what is the bottom line? The bottom line is only one and only one thing in immediate denture, in immediate implant placement, and that is a good primary stability. If you get good primary stability, there is a chance, there's a 97% chance that your restoration is going to be very, very successful. Okay? We had this paper, and my entire study is based upon this, so I'm trying to create a foundation for you guys so you understand where I'm coming from. Extraction sites, Schrupp in 2003 mentioned about the significant alterations in most extraction sites that will occur in the first year. And he talks about the vertical dimensions going down by 1.5 to 2 millimeters, about 40 to 50% decrease in the socket width, with most loss occurring during the first 3 months. This is what he wrote. And the pictures that he talked about was mainly the facial plate. And as you all know, that in implant dentistry, our major concern is the mid-facial recession. That has been haunting us for years and years and years together. That is the biggest problem that we are facing in implant dentistry. Okay? Here is some more literature, but this literature from Fecchi, he published a paper, and he talks about reducing the extraction trauma by limiting the flap elevation. And he says that they are essential in obtaining success in socket grafting and other bone augmentation procedures. We have other paper by Lindy and Melcher that talks about the similar thing, that elevation of a flap might diminish the ability of the periosteal cells to regenerate bone, with an undisturbed periosteum maintains an osteogenic potential. This is what it is. So here's the thing, that if we do not disturb the periosteum or the internal aspect of our socket after extraction, are we not preserving the periosteal cells? Yes? No? Maybe? Nobody wants to answer? Okay. Yeah? So, and then we look at one of the studies by Sands. He talks about the facial plate in maxillary anterior teeth. And you look at the study, and what it basically represents is that most of the facial plate is less than about 0.5 millimeters thick at any point, at any given point. Okay? So we look at these factors and these studies that have been done. Back in 1990 to 1993, there was a lot of criticism that was achieved because immediate placement actually started in 1989. Okay? The first published paper on immediate placement was in 1989, where they had shown a significant amount of success rate. However, since that time, they talked about immediate placement in infected socket, and these are some of the papers that actually criticize the fact that it cannot be done. Okay? So working in an infected area, is it possible? Yes or no? Here is the literature that supports this. But all this literature, okay, All these cited literature, basically when you go through each and every one of them, tells you that you have to, number one, debride the socket. You have to condition or do some sort of an irrigation with chlorhexidine. Okay? You have to use antibiotic. All these factors have to be taken into account to get a good success with immediate placement in infected sites. So here's another paper that Chris wrote, and conclusion was that at 24 follow-up implants placed in infected sockets rendered equally favorable soft and hard tissue integration. Soft and hard tissue. That is important to remember this in the study. Okay? There was another paper published back in 2012, and it was talked about immediate placement in infected site, a case series that concluded that based upon the study, implants placed in fresh extraction sockets affected by an infection may be a valid operative technique. Okay? Then there were several articles written about lasers. When lasers came in, people said, take this laser and start zapping your sockets. Now let me ask you, what does the laser actually do? Laser produces heat, doesn't it? We all agree? And what does the heat do? At what temperature would a cell die? An osteocyte will die at about 47 degrees Celsius, according to a lot of literature that we know about. Okay? And if that is the case, why would you zap it? Why would you kill those viable cells in the socket? That's a big question. Okay? And therefore, I came up with this immediate placement in infected sites. And this is how it all started. This was a young girl who came to my office, and she had some veneers placed some time ago. This was her radiograph. Looking at this radiograph, you can see that there is a radiolucency around number 10. For people who are not from the US, it is 2.2. 2.2, yes? I'm right? 2.2? Okay, thanks. All right. Over here, this is the cone beam radiograph. You look at number 8 and number 9 and number 10. That is 2.1 and 2.2. Okay? And this is what she presented with. Look at this cone beam right here. There is absolutely no facial wall. There's absolutely no facial wall here. The periapical area is absolutely radiolucent. That means there is no bone present. And here she looked at intraoral pictures. We gave the incision, took out the tooth. This was the defect right here. Okay? And when we started the defect, we did some bone grafting, and this was the result. This is the final picture, and I'll show you the results 16 weeks post-op. Okay? A successful integration of the implant without any scraping, without any lasers, without any antibiotics. Because when she walked into my office, she was in pain. She wanted to leave. Her husband is in the army. They were moving to South Korea. Okay? And she says, I want you to do this today. And when I come back, I'll show you my pictures. And this is how it all started. So when we look at her case, one of the critical factors that we looked at was the implant, the type of implant, how much of crestal bone we will have left after we do this, how much of a gap distance are we supposed to get. There were a lot of factors, and without going into the details, let me go to the next slide and show you what we did. This is what we did. And the hypothesis of my study was, number one, that osseointegration is possible in infected sockets. That was number one hypothesis. But it was possible without scraping, without conditioning the socket in any way or form. Okay? There is no conditioning, no scraping, no antibiotics, nothing. All the patients that were seen were patients who have non-restorable teeth. And if they were taking antibiotics, we did not do surgery until about 4 weeks. Okay? So this was our hypothesis. It's not going to be easy, but it's going to be worth it. That's what I told myself, that it is probably going to be worth it because I've done it once. I think I can do it again. Okay? So when we look at, this was our selection criteria. We looked at our sites, we looked at active infected sites with and without any drainage. It could be either one of the two. The active infection site has to be a non-restorable tooth, which means that if it was a tooth that had endodontic treatment, I would send that case to an endodontist and I will ask him, do you think, what is the prognosis of this tooth? And only if they said it was a hopeless prognosis, that was the only time we included these teeth in the study. Okay? And they had to have a periapical lesion of some sort. They had to have some periapical pathology. Okay? So this was our criteria. The other thing that you have to keep in mind that according to Ken, he published this paper in 2010, 81% of the time we are going to find a class 1 situation in the 6 maxillary anterior teeth. That means we have a lot of palatal bone behind that to grab on and make sure that we achieve a good primary stability. And that's exactly what we followed. So we look at these cases, and I'm going to go quickly through these cases. We had a first case I'm going to present to you is with severe periodontitis with grade 2 mobility and acute infection. Patient comes in. This is number 7. This is the one that he complained about. This is what it looked like preoperatively. You can look at the topography. This is the situation. There's a slight periapical infection, not a huge one, but still there. Sorry, I can't see anything. And then what we did was we did some pre-op measurements on the CAT scan of the facial plate, the thickness of the facial wall, the length of the facial wall, keeping in reference the free gingival margin and the clinical crown length that was taken into account. We measured the width of the bony socket from facial to the buccal, from the facial to the palatal. We also took into account the entire tissue width, that is, including the soft tissue and the bone. We included that. And we took some digital impressions by Planmeca's software called Romexes, if you are aware of it. That's the software we use in the office. So here it is. I want you to look at this area and look at this little of dehiscence that is present. We extracted the tooth. Here it is. The tissue remains unchanged. We measure it for our study, and we place the implant. This is peri-op. This is 3 months post-op. Okay? And you can see in this area, look at the amount of tissue that we have actually gained in this area. Look at this topography. Hasn't changed much from when we started. Again, look at the initial. This is the final. This is the final one. This was initial. This is the final. Look at this. Nothing much has changed. As a matter of fact, if you look at the free gingival margin, it has actually moved more coronally. You see that? What a big change. And I've done nothing. I did not do anything other than implant placement and giving a patient a provisional restoration. We did not do anything. Okay? Then we look at this pre-op. Look at the topography of the facial plate here. And then we look at the topography at extraction. Nothing changes. And this is the final. Look at this. Not much has changed. And what did I do? Nothing. Other than implant placement, I did not do anything. Okay? Now we go to the next step. Look at this. This is pre-op and some of these post-op readings that we have taken. This is case number 2 with chronic apical periodontitis with vertically cracked tooth. This is number 9. This is what the patient came in for. It was referred to me by my endodontist friend, and he says, the guy wants to have an implant immediately. I said, okay, send him over. We included him in the study. This is what it looks like. Before, after, you look at this, how facially this is. According to Ken, the article published in 2010, 81% of the sockets in the sockets are usually facially placed. So we have enough room over here on the palatal. So here it is. We did the extraction, measured it, and we have enough room over here. And normally what would people do is graft the site. What did I do? Nothing. Okay? We did nothing. This is a gap distance of about 4 millimeters from the facial plate to the body of the implant. Okay? This is how it looked like. Look at the soft tissue, how nicely it contours around the area. Look at this tissue before and after. And all these crowns that have been made, they were placed subgingivally by about 2 to 3 millimeters. Okay? This is the final result. Again, this is what it looks like. Look at the amount of bone that we have gained on the facial. Isn't that amazing? We didn't do any grafting, nothing. Look at the amount of plate that we have. Here's another example. This is where we were. This is after the implant placement. Look at the difference. Okay? Here was the implant. If you put an implant and measure this length here, and you just duplicate the slide, sorry, and bring it here, this thickness was less compared to what we have here. Okay? And look at this, what happens. From here, we go to here. Okay? And there are no visual enhancement, there's no Photoshop done on any of my slides, just a disclaimer. Okay? This is what it was, this is what we received, and this is one of the cases there where we actually have gained a tremendous amount of bone. About by 1.76 millimeters of bone was gained in this case on the facial plate. Here's the facial bone width. We take that into account. This is another one. This is a case, and this is something that when I was doing my study, I sent it to a lot of my colleagues who do studies, and they are very critical. And I want them to be critical because I want to prove a point. So they said, look, what you're doing is you're going palatal to the actual infected area. I would like to see you go in directly into the infection and place the implants. Okay? So what we did was we placed our implants directly into the sites, and you can look at this fistula right here. This is a draining fistula. This is 8 weeks post-op. Okay? And this is 24 weeks post-op. And I proved him wrong. Okay? Again, I know I don't have a lot of time, but I wanted to show you these cases, wonderful cases that we have. And you can see a large amount of periapical infection with actually draining fistulas. So these are actually infections that we treated, and this is our result. So this is what we found out. When we looked at the, our data, the buccolingual width at from crest to crest, you can see it's very close to where it was initially. The blue line represents the initial, and the red line represents the final. But all these values, over 50% of them, have been very, very close to what the initial situation was. Okay? The same thing over here. All these data that we have gathered over a period of time, this all tells us that we were very close to our initial situation. The average increase in width was about 0.36 millimeters. In any literature you look at in implant dentistry, it talks about the width going down. The thickness of the facial plate goes down. In our study, we actually gained 0.36 millimeters. 0.36 millimeters. Okay? And this is again data going to this. But this is what is most convincing data. When you look at this data over here, you look at our p-values. Okay? If p-values are all 0.88, over here the p-value is about 0.5, that is the borderline. Okay? Then over here you look at the p-values that has changed, but most of our p-values are better than usual. Okay? That tells us, that proves the point that I'm trying to make, and the point is that you can place implants in infected sites predictably and very effectively without having to spend a lot of time and money on the patients. And all these statistical analysis tests were performed under this category, okay? And this is the most accepted one, we all know. So the average changes occurring in each parameters were 0.5, 0.08, 0.21, and we saw a facial bone width increase by about 0.3%, or 0.329 millimeters. We got 100%, 90% success with osseointegrated implants. We had 10% failures. And that failures, I cannot tell you why that happened. Okay, I can only speculate that it has to do something with the bacteria that was involved. But this is just a speculation. I cannot give you an exact answer why these failures have occurred. Okay? We are what we repeatedly do. Excellence then is not an act, but a habit. So if we get into a habit of doing certain things in a certain way and follow the protocols that have been laid or are being laid for the future, I think we will get nothing but good results at all times. Further research is always required, and I think we have to continue innovating and coming up with different ideas that can make implant dentistry more predictable and good for our patients. I thank you for inviting me here. If there are any questions at this point. Any questions? Yes, doctor.
Can you please speculate why, when you put the implant into the socket which was infected,
yes,
why the inflammation receded? Why it healed?
Why did it heal?
Why it
Here,
didn't grow?
yes. The number one thing is that when we talk about any inflammatory process in a tooth, associated with the tooth, what is actually happening at the cellular level is that there is a layer of, it's almost like a bag formation, okay? And that protective bag is actually preventing that infection from invading the bone, really. It's a protective covering that is caused. Basically, infection is, the pain comes from the inflammatory process and not because of infection. It is the inflammation that is causing the pain. So now our thought process is that in a normal socket healing, what happens? If you look at the studies from Lindy, from Schrapp, and all these other people who have published papers after papers, you look at the studies, they will tell you if you did not irrigate or curette an infected site that contains only inflammatory substance in it, it will resolve by its own. And that was what was very encouraging for me, to read all that literature and say, okay, most of it is mainly inflammatory. So if I can go in with my drill, leave the periosteal cells intact in the socket, and during the drilling process, I might get lucky, and I might get that inflammatory process in that drill, and it will irrigate out itself. So this was the hypothesis at the time. But we have proved it because we have a certain protocol that we follow to get success in this thing. So to answer your question, it is basically an inflammation that we are dealing with caused by infection. So if we remove that inflammatory process away, you get nothing but good, viable bone and cells that will help, that have a great potential for osteogenesis.
In the interest of time and respect for the next presenter, let me invite the group to thank you, Doctor, for your excellent presentation. And let me suggest also that further questions at the coffee break or at lunch would be in order.
You're more than welcome to come and ask me any question. I'm around here until 2 o'clock. So, thank you.
Our next presenter is Dr. Yasmin Kote from college in the UAE, and her specialty is pediatric dentistry. She's an instructor at the European University College, and her biography and background is represented in your program. Let me welcome you to your presentation. Please proceed. Thank you.
Okay, good afternoon, and thank you very much for the wonderful presentation. I mean, wonderful introduction, and welcome to the 5th American Dental Congress for today. And I would like to thank the organizing committee as well for a great job. Let me delve right into the topic. And topic today is about caries prevention, and it's mostly based on the evidence-based toolkit that's out there, and it would help us kind of present recommendations for each and every patient that walks into our door. Plus, it's kind of based on the model in the Middle East where I'm practicing. I'll talk more about that in a second. Allow me to introduce myself very quick. And I work at the European University College, just as Mr. Chairman mentioned, and I practice privately in Abu Dhabi. So I work in 2 different cities. And between Abu Dhabi and Dubai, I'm originally from Egypt. I would like to shed light on the caries experience in the UAE, some of the caries prevention tools that we can use. It's not working. And perhaps tailor-make some recommendations, plus talk a little bit about the reality check of how the situation is and what we do. And of course, at the end, introduce some paradigm shifts that would be really helpful in the Middle East where everyone's practicing, because there are things that are practiced still differently. And because we are pressed for time, I will be like picking flowers from a garden. So we open our clinics first thing in the morning, and this wonderful 3-year-old walks right in, and we ask a little bit, so mommy, what brought you here today? She says, he stopped eating, and he has pain at night, and it's severe, and you ask a little bit more about the diet. He says, he's still on the bottle. And okay, tell me more. She says, well, night feeding. He loves it at night, maybe 5 to 6 times per day. And then you ask a little bit more about his snacking habit, whatever. She says, oh, he loves his Galaxy chocolate. 7 times per day, more or less, every day. And that's how it goes. And when you ask about the brushing, she looks at him, she looks at me like, why are you asking me this? And she says, well, he does his brushing. What a stupid question. And then, of course, this Danny, he's as intellectually intelligent, emotionally intelligent as 3-year-olds. He understands, well, this is a doctor. He's probably going to stick one of those needles into me. So why don't I play mommy up and scream bloody murder for the entire time at the office? And, of course, after we get in Danny's teeth, this is what we see. It is chaos, mayhem, and this kid is not going to sit on our chair anytime soon. So the million-dollar question is, and this is every patient we see there, what do we do? And the first paradigm shift of the day is the drill and fill approach no longer works. We don't shoot with the drill and ask questions later. We always start with prevention first. And again, if all the GPs I know that were practiced in the UAE started with this, we would be at a much better position. Now, let me show you what's the population I'm talking about. And I wish I had more studies to show, but because I'm pressed in time, I am generalizing from the and in the middle. We start with 5-year-olds, and 5-year-olds, they just had their teeth in 2 years and a half, and if you look, the decay experience is 83%, and that's huge. And if we look at their DMFT, it's 5.1. A quarter of their teeth are already decayed. If we take a look at 12-year-olds, and their teeth are just freshened, 54% of them have decay, and their DMFT is 1.6. For those 15-year-olds, 65%, and the DMFT keeps rising, which is 2.5. Now, the thing is, these results are based on a national survey, and the national survey, by the time it was published, that was in 2010, and of course, by the time it got written and whatever, all I'm trying to say here is this is an old study. So the caries prevalence now is a lot more, but we do not have it reported as yet. And now the funny thing about icebergs, before you hit them, you can only see 10% of them, and this is only what we see. So this study was diagnosing caries at the D3 level, which means it's an overt clinical lesion that you crawl into and you find. But what about these, what do you call them, sneaky white spot lesions or decalcifications? They are not reported in any of the studies. So all I'm trying to say is that the caries experience reported is a lot less than what is reality. And now you can appreciate that in such a population like this, there is a definite high risk. And it's just not caries, there's dentally uneducated individuals. Majority still seek pain only when there is pain, seek dental treatment only when there is pain. There is no recalls, no regular recalls. The diet is highly cariogenic. The whole culture is about cariogenic food. And I can keep talking on and on and on about risk factors that are present that we're up against. Now, the thing is, it's always so good to appreciate what we're up against and the etiology of caries, and then understanding what link to break in each and every individual that we see. Because again, caries is a biofilm disease, and it's dynamic, but why are we still stuck in the paradigm that we need to eliminate the bacterial film? Why don't we just try to modify it? And how do we do that? Now, again, we have a lot of factors or a lot of tools in our toolbox that we can use for each and every patient that walks into our clinic that we can help modify the caries experience with. Our first tool would be caries risk assessment, and again, another of those paradigm shifts that individualized prevention is the key. We no longer have a one-size-fits-all jacket. Oh, you're a patient, 3-year-old, take it. 4-year-old, whatever. So the thing is, we can never treat our children alike. We cannot treat special needs just like any other deprived individuals, medically compromised. We have to know who we're targeting and how. And the thing is, caries risk assessments, there are tools for us to be able to predict if future caries is going to happen or existing lesions are going to progress. And they were important, again, because we're stuck in time. I'm not mentioning them, but they are important. And the recommendations that I'd be given are always based from guidelines that we have available to us, and they always link the grade of recommendation based on the level of evidence that it is taken from. And the best sources, whether they're British guidelines or the AAPD, the American Academy of Pediatric Dentistry, if you're ever stuck and you need a recommendation, go to one of those websites, and they're free and they're available. Now, I'll tell you about the first toothbrushing advice I need to give each and every patient I see. As first, who brushes? Because they always say, well, he brushes or I brush, but then they brush and the FLAS scores are 4, and you're like, seriously, do you really brush? And each and every patient has to receive the instruction that you have to brush your own kid's teeth. And little tip, spit out the excess space, but do not rinse with post-brushing. And this little tip, being told from a clinician, goes a long way because it helps. Plus, it decreases the fluorosis risk if the parent is more involved. And the thing is, the parents in this population, they're not interested, they're not involved. Only when you tell them, they kind of understand, oh, I need to do this. And of course, bedtime, the importance of pre-bedtime brushing does not happen because they say, well, yeah, I brush. And you say, when? Say, morning. But what about bedtime? And only when we mention it, they realize it. Now, about flossing, do not get me started. If they don't brush, will they floss? So I always give this advice when it's a motivated mother, which is like 5% of patients I see. Again, the techniques for brushing, well, we do not need to go through with all these different techniques on how to brush, what to do, whatever. The evidence tells us that just modify the patient's existing technique and just help them brush systematically. And that's all we need to do. Now, for disclosing agents, I use them sometimes, but the funny thing is, if it's a girl, she'll look at it and she'll be horrified. Oh my God, it looked bad. And she's gonna go brush. But if it's a boy, he wants to look horrifying. He wants to look scary, and then he won't brush. So I don't know what's a win-win situation in this. And again, most mothers, because they don't care, plus, the nanny's the one that takes care of the kid anyway in 80% of the population. So I need to show them how to brush. I need to show the nanny how to brush. And even those little ones that are kicking and screaming, we need to show them how to handle this. They don't know, and this is their reality. And unfortunately, it's our reality too. So now let me tell you about diet. It is my job. Again, I told you about my population, uneducated about the diet effects. And again, our reality is, they love breastfeeding. Breastfeeding takes place until 2 years and plus. They love bottle feeding 5 to 6 times per day. Even at older ages, I've seen a patient last week who's breast a bottle fed at 6 years, and bottle feeding still happens. Now, and they get creative about the baby bottle sugar additives. You ask them, okay, well, so what do you place in the bottle? And they say, milk. Oh, fine, that's great. What else? Oh, sugar. Honey? Yeah, okay. Jam? Oh, God. Biscuits? Yes. Oh, my God, what's happening? And the thing is, they get creative. If they can put it in a blender, they're going to put it in the bottle. They're going to feed it to the baby. And it's up to us to recognize what are they really doing, because they do not tell you the first time you ask. They say milk. And they just smile. But you know from the child's mouth what's happening in there. And again, the funny thing is, because the whole culture is based about eating, the mom cooks something yummy, places it in, and says, well, just go eat. And then every 5 minutes, the kid comes and goes and eats something. And this is a horrible way to feed a child. So now I told you about the reality, and the thing is, there are a lot of hidden sugar traps in the market. Plus, everyone, even the 2-year-olds and the 1-year-olds in their bottle, receive Pepsi. So we are up against a lot. So what do? The thing is, we give them a diet diary, we look for what they're doing, the real thing they're doing, and then we formulate their advice accordingly. And again, another one of those paradigm shifts is that we no longer classify food as bad food, good food. We try to educate them about healthy diet, bad diet. Because if you tell a 2-year-old or a 3-year-old, oh, chocolate's bad for you, do not eat it, child is like, no. You go get a life and have some of it sometime and not be so uptight. It is yummy, and it is yummy. But if I can educate him, eat a chocolate, eat an apple, go brush your teeth, that is a lot more sustainable. And of course, in this message, I have to make him understand that twice a day they have to brush, and then they can eat anything in between sensibly. And this goes a long way too. Plus, recommend some protective feeding, like giving kids nuts after meals or cheese after meals for their positive balancing effect, or giving kids xylitol, or perhaps baking with xylitol products, because the community loves to bake a lot. How about probiotics? Really, probiotics do not have a lot of evidence behind them, so I'm not going to go through them, but they would be interesting if this population has a lot of caries and there's something we can give for us to balance that. Now, the diet advice at the end is, do not give sugar, do not put the bottle, don't. And if I tell you, do not think of that pink elephant running around everywhere, what are you thinking of? You're thinking of exactly that nice pink elephant running everywhere. And that's the same thing for the mother. If you tell her, do not, she's thinking, oh my God, I want my baby to have some sugar, please. And seriously, so what do we do? Again, by the American Academy of Pediatric Dentistry, there's motivational interviewing, and it's really just a counseling technique. It relies on a really open channel between the clinician and the parent, where you are helping them. You're an alliance. You're not the enemy. You're not telling them what they're doing is wrong or making them feel guilty about it, and you start with it one thing at a time. So let's say bottle feeding, you take that, you decrease it, you give them proper advice that they can do. It's personalized. You tell them, okay, well, I understand, but how about decrease that milk content maybe into a quarter for the first week? Try it. How about that? And then it goes a long way too, because they understand that you understand. You're not just handing out some recommendations that you've learned somewhere and you're giving it to them. You actually care. Now, I'll tell you a little bit about the fluoride and really quickly. And again, we all know how to increase our fluoride availability. Now, do we have water fluoridation? Unfortunately not. And we drink from bottled water, and there's just 2 or 3 companies. So I'll presume this population gets no fluoridated water. Now, how about the supplements? Don't get me started on the supplements. We don't get them if we want to. And anyway, whoever needs the supplements does not take them if you prescribe them, and whoever does not need them actually ends up taking a lot of them, hence fluorosis. So again, this is not a tool I can use in my population. So the real actual tool I can use is the toothpaste. So I have to prescribe toothpaste to each and every patient, or they would end using one of those organic toothpaste, because I've had a lot of patients and the caries is rampant. And I would be like, so what are you really doing? And their diet comes up not that bad. So I would ask about the toothpaste, and they would say, well, here it is, and it has 0 fluoride, because the market is unregulated. So, and the evidence tells me that any less than 1,000 parts per million fluoride is ineffective at controlling caries. Then it is up to me, up to all the GPs, up to all the pediatric dentists to prescribe that appropriate dosage. And there is this fantastic document that organizes prescriptions according to age and tells you if it's a smear or a P. And if the caries risk is high, then you go up and upgrade the paste. And only if you prescribe it to the patient, he will follow your instructions. And again, the trick is, according to one of the important studies that happened back in 1999, to use a high concentrated paste, but very small quantities for children aged less than 6 years. So you upgrade the prescription kinda, but you decrease the quantity for it to last a long way. Now, fluoride varnish, again, wasn't available in the market until like 2 or 3 years back, and a lot of people still don't know that it's still there, that it's newly introduced in the market. According to a very good Cochrane in 2013, the varnish application decreases caries by 43% in permanent teeth and 37% in primary teeth, and that's huge. And we want our dentists to keep using that for every child they see. And the thing about varnishes, it arrests existing lesions and it maintains the fluoride for longer in contact with these lesions to be. And just we apply it twice or thrice per year and it would go a long way. And if we give proper post-varnish recommendations, it will definitely help out. Now, I have to hurry with this and just get the varnish, the proper varnish recommendation. And for people with allergy, there are alternative varnishes. Unfortunately, people still use acidulated phosphate fluoride gels. They do bring about 26% caries reduction, but if we mentioned 43% caries reduction, this is not to be used anymore. Plus, the risk of it being ingested because the tray can, you know, a lot of quantity can be placed and improper technique can lead to a lot of problems. Now, there are alternatives to fluoride to fluorides. And one smart guy thought, well, tooth is made up of calcium and phosphate. What if I have a supersaturated saliva with calcium phosphate? What's going to happen? Tooth movement came into play. He added fluoride to it. Then along came MI paste, and there is a varnish with it too. And the preventive fraction for this was 42.5%, which is huge for those white spot lesions. And I'll hurry right up and I'll talk a little bit more about things like these. And I see them a lot. And then what happens is a lot of dentists don't know what to do with them. Some just drill them out. And they're just white spot lesions. They are waiting to remineralize. Just give them a chance. Give them the appropriate things they need. And I've just talked about MI paste, so we can actually just use MI paste. But for the ugly scars, something else that we can use is Icon. And Icon is just like a fissure sealant. And all it does is it seals these pores and helps the surface be intact again. And we can talk later about how to do it. It's not that difficult. And the recall, putting each and every patient on a very strict protocol is really something, because parents are still under the paradigm that we only go to the dentist when there is pain. And this is Danny after we sat him in, explained pediatric dentistry, did all our bit, and what we're really interested in is to provide comprehensive management of a child as a whole, not treat a tooth. We are treating children, and this is our life, despite the pees, the poos, and the pukes. And I always tell my patients, brush the teeth you want to keep, or this will be your end. Thank you very much. Any questions?
A couple of questions. We have a moment or two.
Is there any communication between the dentist and the pediatricians?
Unfortunately, well, I would like to say yes, but most of the time when I send one of those nice referral letters telling them to do something or the other, it gets lost. I'll tell you, there is an important part that I skipped, that the model is really based, the government, only 20% of the population is can get benefit from the government. So only 20% of the population are, well taken care of, but everyone else, the 80%, relies on private practice. And private practitioners do not speak well to each other. They're just in their bubble. So the pediatricians don't have this lift the lip. They only when a child comes and he's in obvious pain, and then they think it's tonsils, and then they go to the pediatrician goes, oh no, that's not mine, go to a pediatric dentist. And that's the only way where there is some sort of collaboration.
Have there been political actions to get fluoride in Dubai, in the water?
Well, to be honest, yes. And since I work at a university, we have a lot of efforts that are going on for us, but the thing is, they are not going to do it anytime soon. And people do not drink from the tap anyway. So you're talking to bottled water manufacturers. And some of them are actually taking action, and just one more product was introduced. Does everybody have that product? No. And does everybody know about it? No. So that's the thing. A lot of people come and say, what is fluoride? Or some know something about fluoride and they think fluoride is bad. So when I suggest, I'm going to put fluoride varnish, you think, oh my God, what are you going to paint my teeth with? So this is what we're functioning from. Any other questions?
Thank you, Doctor, for your lively presentation.
Thank you.
We didn't expect icebergs and polar bears from the UAE, but we
See?
got them. And thank you very much. Please
Don't
join
judge
me
a
in
book by
thank-
the cover.
How do I say this?
Yeah, team one.
Lin Wang. You're going to have to fill in the blanks.
Yeah.
Lin Wang is currently the vice principal of Nanjing Medical University and head of Nagasu Key Laboratory of Oral Diseases. He has assigned as the visiting scholar in Northwestern University and University of Illinois at Chicago during 1996 and 1998. He has been focusing on molecular biology of cranial growth and development for decades and successfully in charge of 4 national natural science foundations in China. He has already published more than 50 peer-reviewed papers in reputed journals and serving as an editor for the board member of Journal of Oral Rehabilitation. Thank you.
Good morning, everybody. Thank you for the introduction. I'm from China. Yesterday, I took the 20 hours from China to fly here. I think I'm happy than my grandfather. 1 century years ago, my grandfather from China take the ship, take the 2 months from China to here. So I'm very happy. It's my pleasure to hear. I take the short time to introduce my university. My university is called Nanjing Medical University. Nanjing is the capital of the Jiangsu province. Jiangsu province is very close to Shanghai. It's the least south part in China. In my university was established in 1934. Right now it's the Nanjing Medical University. We have 2 camps. One campus in the center of the city. Another is more than 10 times the older campus. We have the student total more than 17,000. We have the more than 1,000 staff and faculty. Right now we have the 23 school and department, include the School of the Stomatology. In China, we call the stomatology. In America, the dental school. Yeah, that's the difference. Because in my dental school, we teach some students the oral facial surgery. Yeah. We have the 23 affiliated hospital, include the stomatology hospital. We have a different education system. Right now, in university, I charge of the education. In the stomatology, right now in China, is the top 6. Yeah, we have the different terms looked, the clinical medicine ranked the 5, 7, 9. So today, about the microRNA bind site the SNPs of the FGF genes and the risk of the non-surgical orofacial cleft for us to list. You know, in human gestation is the 6 and the 12. If some factors influence the 6 fusion, maybe can result the craniofacial cleft. In this cleft, the more is the that's the Asia more than Caucasian and Africa. In China, right now is the 1.8 per 1,000. You know, in somebody so from the lift of the cleft, maybe get the so many trouble for the baby and for the family. There are 2 kinds of orofacial cleft. One is the syndrome orofacial cleft. Another is the non-syndrome oral cleft. This kind is associated another congenital anomalies. Another one is the without any major birth defects. Right now, we just focus on the non-syndrome oral cleft. So many factors influence this cleft. 2 kinds, environment and the genetic factor. This time, I will talk about the SNP. Yeah, microRNA bind site SNPs. Yeah, this macro bind site SNPs can affect the interaction between the microRNA and RNA and macroRNA. Then modify the gene express. All kinds of the disease, include the orofacial cleft leak, is related with the SNPs. Right now, we think about if microRNA bind the site SNPs and the FGF genes contribute to the resect of the non-surgical orofacial clefts. We follow the list of steps. Then research of the list of steps with the cleft. The first, with selection of the genes and the SNPs. FGF genetic selection. There are 22 FGF genes were identified. Another SNP selection, we used 3 in silicosaurs. 11 steps in the agents were identified. We collected the sample from 4 areas of the jurisprudence. 602 cases, and another is more than 6 control. We use the DNA extraction and the gene typing. This is the DNA extraction, gene typing. We find 3 SNPs with the cleft in China human population. Associated between the 11 SNPs and non-surgical orofacial research. Yeah, this is 3 eyes, 3 sevens, 3, 6, and another 2 SNPs with the non-syndrome oral cleft in China. Then we researched the synapse function. Yeah, significant difference between the plasmid with the different early synapse when transfected with the microRNA. Synapse affect the gene express the different expression. From the list result, we got the conclusion. Our study found the 3 snaps of the FGF2 are IS10482001, FGF5 and FGF9 were associated with the non-syndrome oral cleft disease in the Chinese population, probably in the by affecting microRNA and mRNA interaction and gene express. Where the results published the different journals include the Natural Communication in 2015. This is my paper published the Natural Communications. Yeah, we have the team to do this kind of research. Thank you.
Thank you, Doctor. We have a couple of questions. Let's wait for the microphone. Dr. Tolarava.
Very nice study. Congratulations.
Yeah. Thank you.
I have 2 questions. You know, cleft lip and palate, this is what I live on for 50 years. So, did you see differences in these SNPs? If you look at subclinical types, or at least if you look at cleft lip only and cleft palate only.
Mm-hmm.
Did you see any differences? That's my first question. And my second is, how many of those from 600 cases were cases with first-degree relatives affected as well?
Mm-hmm. Yeah. Right now, in my research sample, we didn't divide to the lip cleft and cleft and lip. We correct to research. Yeah. Pardon the second question?
Did you look differently for cases with a family history in first-degree relatives and those without, were sporadic cases?
In my study, I didn't divide the family control, just a single child. Well, yeah, in future maybe we correct the family sample. It's very difficult to correct the big family. Yeah, thank you. Yeah.
Dr. Tola.
These SNPs, did they increase translation or decrease FGF expression?
Pardon?
With these SNPs
Mm-hmm.
in place, the expression of FGF was increased or decreased?
Yeah. Right now, FGF just only one factor. Maybe so many factors influence the. Yeah, so many factors influence the cleft lip and cleft lip, lip to cleft. Yeah, so many factors. Yeah.
Yeah. Well, join me, please, in thanking Dr. Wang for his informative presentation. Good. Thank you. Thank you. At this time, let me invite Professor Al-Motadi. Yes, please join us. Professor Noor Al-Tadi has received her doctorate from Cardiff Metropolitan University, and she's assistant professor at Jordan's University of Science and Technology. And we look forward to most informative presentation.
Yeah, can I just like my presentation because I made a few changes, so is it okay?
Sure.
Yeah.
You have the You're finding it?
Is it?
Close and reopen it.
Close and open it.
Close and reopen it. Is it just saw your device? There you go.
Yeah, thank you very much. Good afternoon, everybody. Thank you very much for coming to this conference, and thanks for the organizers to give me the chance to give you like a brief presentation about my last research. I work at Jordan University of Science and Technology for a year so far. Today I'm going to give you like a brief presentation about my last research in Wales. It was a part of my PhD. It's about using a computer-based technique. It's a novel technique for building dental and removable orthodontic appliances. This technique is called 3D printing or additive manufacturing, or we call it like CAD-AM. All these words refer to one technology. It's very much similar to CAD-CAM, which is computer-aided design, computer-aided manufacturing, which is very common these days. But there is like a few differences between CAD-CAM and CAD-AM. So my focus in this presentation on CAD-AM, it's this technique is it appeared recently after the presence of CAD-CAM. Both CAD-CAM and CAD-AM consist of three components. First of all, digitization, which is taking a scan either for the patient's mouth using intraoral scanner or by handheld scanner, which is like extraoral scanner. Both of them should take like three-dimensional image of the patient's mouth or the dental cast. The second component is called designing, which is using the computer software to design the appliance that should fit on the image taken by the scanners and appears on the screen. The third component is called manufacturing. It's a machine that produces the appliance according to the software design. We should, as you see in the picture, the last one, you can see the computer. So this machine works with the computer. And there is a difference in the machines between CAD-CAM and CAD-AM. So that's the difference in the third component. This slide shows you like different machines for 3D printing. There are many in the market, honestly. There are different costs. They produce different materials. They produce different accuracy. for example, this is like a stereolithography is one of them. This machine is very good because it produces objects from plastic. Polyjet machine is another machine as well, like the one who experienced in CAD AM in these machines, he knows the difference exactly. For example, stereolithography, once you turn it on, you can stop it. You can pause it at any time, and then maybe you can continue your work the day after. But with Polyjet, once you've turned it on, you can't stop it. So there, it's this thing. It's related to the applet that you want to build, and I will talk about that later in this presentation. So the CAD AM, it's very common in industry, honestly. It's in industry, and now it's been introduced to dentistry. It's been used very common in maxillofacial prostheses for building like noses, ears, ears. The difference between CAD AM, this technique, and the CAD AM, CAD CAM is called milling. CAD AM is called 3D printing. This technique can produce any design with cavities, with sinuses, with any irregularity. But the milling cannot produce these sinuses and cavities, so that's the difference. And it's been produced also in the removable partial denture. As we all know, the removable partial denture have like straps, have clasps. It's very like tiny, small parts. And it's been produced as well in lingual orthodontics from gold. So as you can see, it's been spread in all fields in dentistry. For example, maxillofacial, it can produce it from a plastic or from wax. For RBD, from metal. For lingual orthodontics, from gold as well. So different materials as well. In this research, honestly, I've used freeform modeling plus version 11. It's a software, it's a freeform, it's not a dental version. That was the facilities of the challenge of using this software to produce the appliance that I will talk about in the next slide. This software works with three-dimensional mouse. Which called a phantom arm. With this design, with this software, it was a challenge for me, like to develop this free-form software to produce dental appliances. So from the tools that it's in the software, I could identify the undercut of the cast. As you can see here, the undercut shows in blue color. And you can also select the correct path of insertion. It depends on the applet that you want to design. As well, I could with this software block out the undercuts automatically by just one click. So that was very easy. Honestly, it's easier than making that with hands. The objectives of the research was to explore the possibility of building the following devices from intraoral scan using additive manufacturing technology. The appliances that I tried to produce and developed in this study were inclined blocks of a Newport style twin blocks. The second one was sleep apnea appliance, incorporated 4 rotating hinges, all in one build, all in one piece. And the third one was building alloy components and inserting them in a retainer. It's like Adam's glass and metal, and inserting them in a retainer of plastic. The methodological approach to undertake a series of case studies, which each device formed the basis of a single case study. Of course, it's a developing study. So whenever I've tried to build a sleep apnea device, for example, it didn't happen from one click. It took months, weeks, and maybe one of them like years, you know? So that's why it's like a series. So, and the first one I produced, I called like version 1. The second one, if it's better, I called it like version 2. And so far, till I got the final one, the most successful one, and I called the successful version. There was a parallel study talking about that it was RPD. The studies were it started on dental cast. They scanned a dental cast, not the patient mouth. So they scanned the dental cast, and they used general version of a free form, and then they produce this RPD from a plastic pattern, and we all know that we need like cobalt chromium, so they had to flask it, deflask it, and you know, investing and all this process till they get the metal. So that was like a long process, and a lot of problems appeared as well. Then they moved, when their process was great, to use intraoral scanner instead of taking the impression, so we can decrease the steps of taking impression and the problems associated with that and the disinfections as well. So I hoped in this research developed here can follow a similar path in the future. So that's what but I used it to develop orthodontic appliances instead of RPD. So I started with dental cast with general form to produce a plastic pattern of orthodontic appliances, and later to produce orthodontic appliances from metal, such as clasps, and now I'm working on using intraoral scanner as well. How to achieve the objectives? Yes. General version of a free form and dental cast as a beginning. The first one I've developed, it's called a sleep apnea device. As you can see, this is the like virtual version. When I say virtual version, it means the design that appears on the screen. So that is it consists of upper plate fit on the upper jaw and upper teeth like buccally, lingually. The same on the lower, and they are both connected with bars from both sides. You can see here, this is like a bar, and they are called hinges. So on each side, there are 2 hinges connected with 1 bar. In this image, you can see like 2 different colors, but actually they are one material in the screen, but I've changed the colors to be clearer to you. So the idea here, I had to make like a gap between, you know, like the blue color and the yellow color, like 0.5 millimeter. And again, there is like a gap between, like internally and from the side. So there was a gap here, and a gap here, and a gap from the inside as well, to enable the hinges to move, to rotate. And in this way, it can move the lower forward. And that's why we can treat the sleep apnea patients who, like, or the snorers. Is that clear? Anyone has a question? Yeah, here. Yep. So, and that's how it appeared. And then when the design was ready, I sent it to the machine, and it's built from a plastic, and that's how it fits on the jaws. So it wasn't like easy, like to find the correct, like, you know, the space, how much it should be. It wasn't easy. Like, I've made so many, honestly. Some of them were broken because the gap was not enough. Some of them, the hinges were not very strong. They were not very thick. That's why they broken very easily. So I had to make so many till I get this dimensions. The second one, because most of the orthodontic appliances consist either from metal or plastic, so I've tried to build like a retainer like a base plate and Jackson clasp on the incisors, plus like a C-clasp on the molars. And it was possible. Like the way of doing that, I drew the clasps on the cast straight away. And as you can see here on the cast, they look like pink, because with this software, I could make the cast as a buck. Buck means like I can't make any deformation. I can't make any changes. If I like click on like if I want to scratch it, nothing happened. So it means it's protected. So and that was very good. So this means if I want like to trim or to delete these lines, it will not change anything on the dental cast itself. So it's protected from scratches as well. So I drew the Jackson clasps on the insides are the same on the molars, and I connected them with a base plate. That's how it looks on the virtual image, and then I built it from a plastic. They were successful, but not 100% because the clasps were plastic and the connections between the clasps and the piece were very weak, so it was easily to be broken, honestly. And the other way, I tried to make like here, like to thick the area here, but it was like bulky and uncomfortable to the patients as well. So I tried to think in another way. What about like building the clasps from metal and connected these with base plate as it is like close to the actual retainer. Yeah, so I've tried to, now I'll try to build labial fitted bow and Adams from metal and insert them in a base plate, and that was very difficult because they are two different materials. They are very much different from the previous two appliances, and the problem as well, the Adams class doesn't fit on the tooth itself. There is a gap between them, so I had to build like guiding jigs before constructing the Adams class. So I had to make the guiding jigs here in certain dimensions in a way like the Adams should fit 100% because drawing should fit in, should contact a surface. So I cannot like draw without a surface. So I had to build these guiding jigs and then remove them later, you know, just like for building the appliance. So yeah, and yeah, that's how the Adams clasps and the labial fitted bow looked like. And I had to build, you know, the Adams and the labial bow, or I should insert them in the base plate all at once because it's a layering that the additive manufacturing technique is called additive or layering. So all the appliances should be built layer by layer, and they should be there should not be like they should be on the same plane. So I had like to start building. I had to start building the base plate. Can you see here the plane? From here till I get to this plane, then I paused the machine, the polyjet machine, then I inserted the appliances, and then I inserted the Adams clasp and the labial fitted bow, and then or turn on the machines again till I get to the final. So I couldn't like build them together. I should start with base plate, pause the machine, start again till I get this form. And the last one, I think, or maybe the one before the last, it's called a Newport 20 block. It's myofunctional appliances, as we all know. It uses to forward the mandible. So I tried to, there is like a Newport style 20 block. It's related to Newport area in United Kingdom. It's about like a base plate on the upper, base plate on the lower, and there are like blocks, one block anteriorly fit on the lower without Adams, without any metal components. So yeah, I used this design to build it using additive manufacturing and using the freeform software as well. And everything was successful, honestly, with that one. And I tried it in a patient mouth, and that was great. The fitting was okay. The issue that solved with this technique that I didn't have to finish or polish of the plastic, so it saved time, and it no need to use like bears, no need to, you know, like to keep you busy like with finishing and all these steps, and the fitting was great. Yes, and again, like the last one I've developed in this study as well, Andresen. We all know like Andresen, it consists of plastic, or maybe like acrylic, connected the upper with the lower with a labial bow. And it's been developed in this study as well. I thought it's gonna be very easy. I could only like build the virtual Andresen and make holes here to insert the labial bow, but that was wrong because the holes were closed, were blocked, because they were very tiny and it wasn't easy to insert the labial bow. So I had to think another way. I had to build like guiding jigs for the labial bow. If they fit on the guiding jigs, it means they will 100% fit in the whole appliance. So I had to build the virtual, the hole, and at the same time, the guiding jigs. And then when I say like build it virtually, then I had to build this physically until I get it like this with plastic. Then I made the labial bow and it fit okay. Then I built this with labial, with the machines, like again, start the machine, then pause it till this level, till I can insert the labial bow, then restart the machine again. That's the final Andresen, how it looks. So with these techniques, okay, we can like skip the step of taking the impression, pouring the impression, transfer the impression, you know, the problems with the alginate, the problems of not pouring the cast on the impression on time, the miscommunication between dentists and dental technicians, all these problems are avoided with using the digital casts. So again, these are the steps, version 1, version 2, version. These are all the difficulties I've encountered, honestly, to produce the Andresen. I had to produce like 5 till I get the last or the most successful one. The potential benefits of this technique, a successful application of additive manufacturing in building dental devices from different materials, which is good. Like with this technique, we can use we can produce dental appliances from different materials, as you've seen here, like acrylic or plastic. We've used like metal. Sometimes with these machines, we can produce it from wax, and then we can, like in maxillofacial, and then we can transfer it to acrylic or to silicone or to whatever. No need of great skills and experience, like with using the software. There's no need for experience for the dental technicians. It's just like you can drag and you know, it's like any software, it's easily. No need for physical room to keep the dental casts. And it's a very good point, I think. And you can just save the virtual scan of a dental of patients in the computer, and you can go through it at any time, and you can save it. It doesn't take any space, and it's protected from scratches or lost or anything. You can, and dental casts are protected from damaging during building as well. As you've seen here, it's when we convert the dental cast to buck form, it means it's protected. If you need to make any changes, it doesn't affect it. Also, sometimes like when you make like a buck, you make like undercut, block on the undercut, then you can transfer it all into the buck. This means the blocked out undercuts casts are protected. And that's the end. Thanks for listening, and I'm happy to answer any question if you cross your mind.
Thank you, Professor. Let's give a thanks. Perhaps there are one or two questions that people would like to pose. Questions? Ms. Lieberman.
I worked on a study where we were scanning and comparing digital dentures to traditional dentures. And when we were putting the powder on and using the scanner, we had issues in the maxillary vestibule. Have you had any issues with that while you're scanning for your retainers?
Why I'm scanning?
Adapting the wand up into the vestibule.
Say it again. What I needed from scanning, do you mean?
Okay.
Can you say the question in another form?
When you're scanning the maxilla
Yeah,
and you're working in the vestibule,
yeah.
do you have any issues with the size of the scanner to get all the height of the vestibule and all of the frenum?
Yeah, I think there are different types of intraoral scanner. I think you asked about intraoral scanner. I've used one of the best, maybe intraoral it refers to 3. It wasn't like very easy to catch all maybe the posterior areas, but I think with experience I get it much easier and better, honestly. And it didn't have to like maybe spray powder or something like. Other intraoral scanners, you should separate like a powder before you scan, and that's uncomfortable to the patients and as well to the clinicians, so he cannot maybe like recognize which areas were scanned or which is not. So with the intraoral scanner that I've used, it was easy, honestly. It was hard maybe for the first and the second time, and then everything was okay. So with experience and training with the trainer, I think it will be okay.
Good question. Other questions? I'm afraid, Professor, that we're standing in front of lunch.
Yeah.
Let us once again thank you for your presentation.
I think maybe with the scanning, it's much better for the patients. You know, some people like gag, maybe when you take an impression for the upper especially. So the scanning is much easier. So, and they didn't have to open their mouth for long, or for people who have like saliva problems. And
Thank you again.
Thank you very much.
Thank you.